Noon. I want to first say that yesterday and today has been for me a learning experience. I've learned a lot. My specialty is organization and development of health services. And even though we know the general aspects of some of these specific disease, some of the very intricate daily management issues that have been discussed here gave me a lot of information and things to think about. Am I going to have the... I got it. Okay, when I received the invitation, I was asked to speak on the subject of providing integrated services to support people with non-communicable disease in the Caribbean. And I went ahead and prepared my presentation, but after the session yesterday, I decided to make a change. And the technical people were very nice about me changing things at the last minute, so I'm fortunate. I'm thankful. So what I'm really going to talk about is the integrated services to support chronic conditions. Taking into account that the advances and the current knowledge and capacities to deal with people with HIV, living with HIV/AIDS and other diseases tends to prolong their lives, and these conditions become more long-term conditions that require a different approach from the health services, a different type of organization from the health services to be able to. So it's not only non-communicable diseases, as in the previous title, but it's also how we deal with people living with HIV/AIDS in the context that those people, in addition to HIV/AIDS, can suffer from other conditions. It's important to understand that these health systems and services are not static organizations. They evolve, they change priorities and focus depending on the realities of the moment. And for instance, in 1920s, the focus was on sanitary campaigns, improving the conditions in which people lived, and attacking mostly parasitical diseases and diseases that could be corrected with improving sanitation. Between 1920 and 1940 were the first social security systems. It was trying to ensure improved capacity to provide health care and services to working populations. And then came along the beverage model, welfare state system, which amplified that from not only workers, but the overall population. In the 1970s, we embarked on primary health care, health for all, based on the discussions in Alma-Ata. And then came what some of us considered a setback in the 1990s when the financial institutions were focusing mostly on cost containment, and health became something like a secondary objective of the system. From the year 2000 till now, we have been building systems and capacities to renew the primary health care goal and to transform health systems toward universal health. Transform the health systems to provide care for all and to protect the right to health for all people. In that sense, one of the things that we need to consider when we talk about health systems and services is that they are very complex organizations, and the care of long-term care delivery requires not only doctors and nurses and maybe health centers, but it's a very complex a very complex system that requires intensive numbers of human resources, intensive financing, and also oversight and governing capacities to ensure that the systems work adequately, provide quality care, and protect the population. Essential to understanding health systems of today is understanding the model of care, okay? The model of care, or what is our main objective in organizing the health systems and services, is a central aspect of that will determine how we govern the system, how we finance the system, what resources we need, and then how we provide services. And that the provision of services, or what people receive at the health center, the hospital, or at the clinics, is a result not only of what happens in that establishment, but is a result of the other functions such as the financing, the policies that come from the stewardship and regulations, and the training and investment in human resources. Since the model of care is essential, then when we look at health systems and how services are provided, it's very important to understand that in the current moment, what is happening in most of our countries is that we have a conflict or a transition from the biomedical model of care that puts doctors, hospitals, okay, at the forefront in comparison or in conflict with people-centered health services or people-centered care, which puts the person, families, and community at the center of the delivery and of the organization and delivery of health services and of the care that is provided. And I will not try to go through all of this because it would take maybe too much of my time, of your time, but there is, in most countries, this transition, and when we look at the health services, we can tell immediately if in fact the policy decisions of the governments to move toward people-centered health services is advancing, or still on the ground, what we're facing is mostly biomedical systems, biomedical services being provided. So what's the problem with biomedical services? Biomedical services are centered around providing care for episodic curative problems. Patient comes with a disease or a problem, and we deal with that. The patient leaves, and there's almost no follow-up. It's based on providing care for people who already have a disease or people who become ill. One of the main problems around providing care in this manner is that it becomes very fragmented, okay? We divide the health services in priority programs or vertical programs that provide services to a determined section of the population without any interrelationships, okay? And that fragmented way of organizing the services produces exclusion and equity problems. Added to that, in many instances, we also provide fragmented care to the individual. In the ways we organize the provision of services in most of our health centers is that we organize specific days for specific care, okay, or for specific aspects of service provision. And if a patient or a person requires services in a day that is not their program, then it becomes a barrier because we refuse to provide. And I was sharing with my colleagues that I saw that experience recently where a gentleman about 45, 50 years came to a health center around 11 o'clock in the morning, and we were there on a visit, and requested to see a doctor. and he was told at that center today the program is from MCH, maternal child care, and that they weren't seeing adults. And this person had to leave and seek, I hope he was able to find assistance at another place. But so when we fragment care, when we organize the services around specific days for specific programs, people are left out, and it becomes a barrier towards receiving integral comprehensive care. So in that case, two of the main problems of the current health services in most of our countries is that, one, the services are organized in a fragmented manner and does not allow for continuity and comprehensiveness. And two, care, even within one establishment, is fragmented in a way that exclude people and creates problems in equity and access to services on a continuous basis. So our proposal is the development and transition toward people-centered care. Care that puts people at the center of the equation, and whose focus is to keep people healthy, not wait till they are sick or they are suffering from some type of problem to initiate care. But that care is initiated throughout the life course. While people are healthy, try to prevent and avoid the need to use curative services, but also strengthening those services in a manner that we're able to respond to the needs of people. So in this spectrum, Integrated Health Center deals with health determinants, right? In looking at the conditions in which people live, work, and interact, look at the risk factors that populations and individuals are subject to, work towards avoiding the preclinical stages of disease, but once disease is established, is able to provide care for the clinical phases, the complications, and the disability. In that sense, the system organizes from health promotion, comprehensive care throughout the continuum until palliative care, and organizes the services in the first level of care and specialized care in a way that it also has interactions with the communities and with the families and with other social sectors in society to improve the capacity to respond to the needs of the population and especially to the social determinants. In that sense, people, family, and community-centered care is based on the principle of promotion of health and well-being, not only caring for disease and sickness. It focuses on people as a whole and not on disease or organs or sections. And it provides care for all people with a focus on people, not only patients. And sometimes I have problems with that discussion because we talk about patient-centered care. But when we speak about patient-centered care, we're speaking about people who already have a disease or a condition when our objective is to improve the well-being of people before they get to that stage, of the continuum. So in this sense, when we speak about integration, it has to do with how we combine the processes of care, the methods and tools that facilitate the delivery of comprehensive and coordinated care for people and families throughout the life course. For that, we require the organization of the health services to be integrated, not standalone activities, not hospitals separated from first level of care or primary care services, but organized in a way where there's a continuum of services provided according to the need of people and populations and not on the need of those who serve in the health services. That integrated care should be the result of that continued care as experienced by the users that are not affected by the fragmented organization of services that leads to a lot of inconvenience, a lot of negative experience for users when they have to use these services and when they have to traverse the system. So integrated services require the coordination between all parts of the health system, all parts to ensure the satisfaction of health needs and their care over time, as well as across the different levels of providing care. In that sense, the organization integrates first level of care services and all other services, not only hospitals, that are required for providing care and well-being for individuals. And it's important to understand that it's not that we believe that hospitals are secondary or not important. In the biomedical model of care, hospitals occupy an important or the center of the system, and even from the financing aspect of the health expenditure, more money is put into hospitals than into the first level of care. So what this produces is that we're putting more money into disease-oriented care rather than increasing the capacity of the first level of care to provide health services and to protect populations from the risk of becoming ill. So in that sense, integrated health services puts an emphasis on the first level of care as a first point of contact for persons and families by assigning a specific population and a specific territory to provide care in a way that providers and users become familiar with the services. The providers know their territory, know their needs, and provide services based on the specific needs of that population. Hospitals and other specialized care centers, and we know now that there are dialysis centers, there are cancer treatment centers that work independently from hospitals. So hospitals are not the only specialized, facilities that are in specialized care, but there's a multiplicity of new ways of providing curative care. And that allows for a different type of organization in the provision of care at the secondary and tertiary care. The important aspect of health services based on people-centered care is that the organization and management puts people needs at the center of what is organized. They're not organized around a specific and cookie-cutter organization that says that each region or each facility needs to have this type of configuration, but it's based on a configuration that is established based on the needs of the population that is going to be served. And the services need to be able to provide care when people need it, that care that is user-friendly, and achieve the desired results of improving care and well-being for the population. In that sense, integrated health or people-centered integrated health services put a specific focus on strengthening the first level of care or primary care. Why? Because it should be the preferred point of access, preferred first point of access for all health needs. Second, first level of care teams should act as a point of coordination and facilitate the experience and the care of people throughout the continuum in a way that is favorable for the users. And these teams require in-depth knowledge of the people they serve. It's not a matter of just sitting in the health center and waiting for people to come, but above all, to know the specificity of the population that is being served, the needs, and also the determinants and the possibilities of interacting with other sectors in improving health and well-being. The first level of care needs to be, as I said before, the coordination center in the health services continuum, and it needs to create those mechanisms that will facilitate the interaction between the first level of care and other establishments in secondary and tertiary care that would allow a comprehensive and integrated care of patients and the return of those patients to their communities under the surveillance and additional care of the first level of care teams. Important in characteristics of the first level of care is that it should be multidisciplinary. It's no longer organizing care around doctors and nurses exclusively, but around those disciplines that are required to respond to the needs that have been identified in that respective population. So the multidisciplinary teams can be different in each country, and even could be different in regions within the same country, depending on the needs that are identified for that network. Because the network responds to a specific population, then each network, based on the needs identified for that population, could have a different configuration of the multidisciplinary team. But what is important is that multidisciplinary team at the first level of care be the first point of contact of the population, of the residents of that region with the health services. And then the question comes, what about the priority programs? We no longer call them vertical programs. It's not the verticality that is important, but what is important is what priorities in the population require specific organization, management, and even funding to resolve. As in the issue of chronic conditions, people living with HIV, etc. Priority programs are important because they focus healthcare on the specific needs of groups. But on the other hand, they should not be segmented in a way that creates stigma and discrimination, as you have been discussing all day. So the Integrated Health Service Delivery Networks proposes the integration of these priority programs into the overall care delivery at the first level of care by strengthening the capacity of these delivery teams, provider teams, to address the different priority groups, the different priority programs, without creating fragmented care and providing that care, for instance, as we saw on the first slide, on individual days that would allow, in fact, the identification of these groups and create the conditions for stigma and discrimination. And the last important aspect about building integrated health service delivery networks is the life course approach. It is known that risk factors can be present even from the prenatal stage of life and accumulate during the different stages of life, and that interventions in health can either increase, or the lack of interventions can increase those risks or can assist in decreasing the risk and the effects of these risks and social determinants on health on a long-term basis. In this graph, as you can see, The life course approach also takes into account not only non-communicable diseases, as in diabetes, cancer, etc., but also the needs and the characteristics of long-term care for people living with HIV/AIDS, and notes that the prevalence and risk at different stages of life produces a window of opportunity for improving delivery of care and planning for interventions to impact the NCD epidemic. In that sense, then, life course approach allows us the opportunity to support positive life trajectories at the same time that we work on preventing negative life events that will lead to chronic conditions. And that's why it's important to abandon the vertical programmatic aspect of age-related care and implement in the first level of care the life course approach. In concluding, integrating services for people living with HIV, for people living with chronic conditions, for people living with non-communicable disease demands a complete system transformation. It's not something that we'll be able to accomplish by one program or one project or one level of care. It needs to be a system-wide transformation that pushes towards people-centered model of care, that puts the focus and the emphasis and the monies and the services on the needs and the perspective of people. And for that, it's very important that groups like yourself are important actors and players in the transformation of the system. It's not a technical issue, it's a societal issue, and it needs the input of all those who are involved, all who are, need the system, and all those who will benefit from it. And second, we are proposing that health services cannot continue to be disease-oriented, vertical programs. It needs to be based on an organization that allows the delivery of care throughout the life course, and also on a permanent basis, and that care is organized within all health establishments based on the needs of people, integrated, that health teams are able to provide care on an integrated basis, and that includes the priority programs and includes all programs. And based on the discussions that I've been listening to today, also will improve situations in health facilities to avoid stigma and discrimination of people living with HIV or with any other disease. And finally, organization and care needs to be based on a life course approach based on the knowledge we have that the risk that leads to ill health and negative outcomes in health are not specific of a day and a moment, but are built throughout the life course, even those behavioral aspects of many of the disease and conditions that we're facing now as an epidemic in most of our countries. Thank you.